Hello everyone. So my name's David Wilcox, and that's my title in the NHS. I think Izzy found me on my private work access originally, but I've been in the NHS now for quite a while. So I'll talk about my NHS role and a bit about the private therapy that I do as well. So I'm going to just put this into a into the playing format for this anyway. Okay. So yeah, just before I sort of went into mental health, I didn't have any background in mental health at all. I was in a military band, and there's a couple of pictures with me in it in the band that I was playing a few years. So when I was growing up, I wanted to be in a military band, and I got there and thought I didn't really like it that much, so I didn't stay very long. I did it for 4 years, but that comes relevant later on, really, in terms of my career, really. So that's and I can see the bottom right. I was in because date says how old I am. Really, I'm in the picture from the bottom right in the first Gulf War in 1990 and 91. So I went there when I was 19, and really, sort of from there I went into my mental health nurse training. So what I'm going to do is I'm going to talk a bit about sort of the different parts of my role that I've done. So I'm a mental health nurse by background, and I think I'm in a bit of an unusual situation in my organisation, being in a senior clinical role but not being a psychologist. I actually supervise a lot of psychologists, which I'll talk about shortly. So I did my nurse training in Cardiff, went directly from the army into my nurse training, and I just decided not to do it in the forces. I decided to come out and do it instead. So I did my training in Cardiff, and I completed that in 1995, and then I went on to work on acute mental health wards in Whitchurch Hospital in Cardiff first of all, and then in Bath. I went on to be a charge nurse. So I put a bit on each of these. So the way I've set this out is to go through each of the roles and talk a bit about what I've done in each of the roles. I thought it might be useful to you to know what sort of things you do in each of these roles. So when I did my nurse training, it wasn't a degree qualification then, but it is now, and probably just as well, because I don't think I would have got in if it had been a degree course at that time. And so working with acute, so I've always worked in acute adult mental health, really, sort of where I found it most interesting. So on acute wards, you're working with people who typically, I mean, I think there's been a change since I've been in. There was way more wards and way more acute beds when I was in an inpatient ward in the late 90s. There's been a massive change over the last couple of decades with what the availability of mental health is. I'm sure you're aware. There's the hospital where I did my training in Cardiff that's been completely shut down, and there's no longer a psychiatric intensive care unit in Hillview Lodge in Bath. They've got a couple of wards there, but it used to be much bigger than it is. So it's all been whittled down, really. So the effect is that when there used to be wards, mental health wards used to be, well, not necessarily as chaotic as it seemed to be now, because you had some unwell people, but also some people that wouldn't get on a ward these days because they're more of the perhaps more of your depression and those sort of cases. So that's where I worked in acute mental health. I started off, and then a charge nurse on the intensive care ward. Obviously, that was quite a chaotic ward at times, but I think what was I think it's a workplace that is good. It depends more on who you're working with, and actually the team you've got with you. If you're with a very volatile and risky client group, I think if you're in from a nursing capacity, if you're with a good team and you have there's good communication amongst the team, I think people can enjoy their work there. And actually, I find it really rewarding being working on there for a while. So roles and responsibilities, it's fairly standard on a ward. You're looking after the people on the ward that are coming in with all variety of mental health problems. Quite a lot of people with bipolar disorder, and then of course you get more. When you get to a intensive care ward, you get more that are more disturbed and on sections of the Mental Health Act and so on. So you get more that are detained against their will and so on. So that was so my early experience in nursing that took me up to about 2000. My first sort of 4 or 5 years was spent doing that, and then going on to if I can get the next screen up. I don't know going on. There we are. So then after being in acute mental health, then I went to work more in liaison psychiatry and mental health liaison. Same thing, described differently. So first of all, in Swindon, I was the first of the mental health nurses to be based in A&E in Swindon. First of all, it was the Princess Margaret Hospital, and we all shifted hospital to the Great Western Hospital. And we were right there in the middle of A&E at the time. Then moved on to be a clinicalist manager in the brand new liaison team in the BRI in Bristol, which is now a big liaison team with an out of hours provision and everything, and it's quite big. And what I started introducing, particularly in the when in both of those units there, was cognitive behavioral therapy, to be able to do that with people with co-occurring physical and mental health problems, because that was obviously that's the client group we've got there, and that's your remit there. A lot of the work in liaison is to do assessments following people attempting to take their own life or take an overdose and that sort of thing. So these episodes of self-harm or suicidal behaviour would turn up in A&E, and then the kind of bread and butter stuff of liaison psychiatry teams is to do those assessments and be able to make a care package, send people home with. Okay, but in addition to that, I set up a clinic with the inflammatory bowel disease part of the hospital, and also I was running a stress management course for people with in the cardiac rehab part of the hospital, in cardiac rehab. A lot of people have anxieties following a heart attack or coronary artery bypass graft surgery. They'd be having issues with anxiety, because of course, when you have a panic attack, I've been told by people there that a panic attack feels identical to a heart attack, certainly in their experience. So there's a lot of obviously anxieties about their health and so on. So we'd be called into those areas to work more there. So there are sort of the psychologists working in general hospitals, and so that's going alongside there. But certainly as delivering CBT there, we were doing bits of that across different parts of the hospital. I know in the liaison service in the BRI, they're now doing some more work with St Michael's hospitals. They're dealing with pregnant women, and also in intensive care, where there's a specific phenomenon around PTSD from people having trauma from their stays in intensive care, and various other things like that. So there's lots of endless potential with liaison psychiatry to be involved in more and more areas where there's co-occurring physical and mental health problems. So it's a fascinating area to be working in, and certainly the Swindon service was very much a nurse-based service, and the Bristol service was very medical model, so very much led by the psychiatrist. Hence these the difference in the names of the service: mental health liaison or liaison psychiatry. Which I haven't put it in the Bristol when it's liaison psychiatry, and that's usually when it's led by a psychiatrist. Then I went from there on to work in Bristol, where there's in Cardiff, where I went to work with where it was a joint post with liaison psychiatry, a bit of the doing assessments, but also is more doing CBT and therapy, both with liaison patients and with the traumatic stress service in Cardiff. So that's my first taste of working in a trauma service as such. So my roles and responsibilities there would be doing more sessional stuff around assessment. So I was largely part of the assessment for the traumatic stress service, so assessing for suitability for trauma-focused psychological therapy. At the time, it was more trauma-focused CBT and the like there. And at that time, around 2008, is when I did my initial EMDR training, which would then become more of my role later on. So from there I went into IAPT, so improving access to psychological therapies. So I was contacted by IAPT to see if I'd be interested in being part of the new setup. It was in 2009. It was where they were setting up the new IAPT services. So these were spread across the country, and I it's something that you all may be aware of. So in 2009 they went to revolutionize the way that mental health problems are treated in primary care, and that has happened. I mean, it's there's some critics around what IAP delivers, but they do a lot of therapy, large amounts of therapy for people in primary care for depression, anxiety, and related issues, really. So there's just really sort of a lot of work goes on there, and it's hard to imagine really what the provision was like before IAP services. So I was first of all a senior therapist in Gloucestershire. I was employing lots of CBT therapists to work in the service there. I think I employed about 50 people. I was on the interview panels, and we had quite a few were high intensity therapy trainees. So these are often mental health nurses and similar occupations who would then be going into having high intensity therapy training. So quite intensive training on becoming CBT therapists in a very much an IAPT model. And from there, the opportunity came up to lead the service in South Gloucestershire. So the Gloucestershire NHS Trust took on the contract for delivering an IAPT service in South Gloucestershire. So I was doing that for a few years as well in my local areas where I live. So so that was then more leadership stuff, more clinical leadership. So I'm looking at the model for how we should be delivering it in South Gloucestershire, and also looking at the local particular issues around the area you're living in. It's quite interesting in the different areas. What we have in South Gloucestershire, we have quite a few, quite a large travelling community relative to the size of the county. So that was an interesting challenge for us to look at how we can perhaps make headway into offering some help to the traveller community. I don't think we ever really grasped that properly. It's a very difficult community to get into, lots of challenges and resistance from the community in general for outside help, but that was something that we were working on trying to improve with that. Of course, a few years ago, the South Gloucestershire and the Bristol IAPT services were taken on by Vitaminds, and they had a 10-year contract then, so they'll be running that service for a little while at least anyway. But that was my experience of doing IAPT in those areas there. So then we come on to the areas where it's we get closer to my personal interests and the skills and leading to where I am now, really. So I put the coverall heading there for veterans and trauma. So in 2012, I took on the lead position of the clinical lead for the Southwest Veterans Mental Health Service, as it was then. There's a regional service for military veterans in the areas, part funded by the MOD and part funded by the NHS, to provide a service for ex-military all around the place. So of course, there's an expectation that a lot of that is trauma, is service-related trauma. And so we set that up, and that's still running now. It's when I was running it, it was we only had a very small amount of funding, and then the funding was massively increased much later on, shortly before I moved on to another service. So I left that service in 2019, having been in it for 7 years. And whilst I was leading that service, I also expressed an interest in the fact that in the trust, the response to staff members being involved in traumatic incidents was very poor. I was informed of a case where somebody was involved in a trauma, and they were told to call occupational health, and had a very disinterested or unhelpful response from them. So I set up a service then, which I'm still leading now, the traumatic stress service for staff. And we actually had a traumatic stress service. We started a traumatic stress service under which a number of smaller services will it's like a cluster of services, really. So alongside myself, there was Dr. Mary Griggs. She set up the asylum seeker and refugee service without any funding also. And that's now achieved funding, is now the Hope service that some of you may have heard of, and that's doing some great work with asylum seekers and refugees, but still under the umbrella of the traumatic stress service in AWP and specialised services in AWP. And so more recently, my role has evolved to be more a trauma lead for specialised services, and also because of the fact that I'm up until very recently, I've been the only EMDR consultant in AWP for the last 5 years. I became an EMDR consultant in 2005, and I've been the only person that's been basically in order for anyone to progress in being a accredited practitioner and so on, they need to have. I'll talk about this in a bit more detail about the EMDR, but basically, so the only one that's been approved to provide to provide supervision for EMDR practitioners as an EMDR consultant, and for AWP I've been the only one able to do that for the last 5 years, until my colleague Mary Griggs, I've mentioned recently, she also became an EMDR consultant. So I will talk a little bit more about trauma and EMDR, and I'll perhaps be asking if what people already know about those things, because of course you're all interested in the areas. You may know, I may be teaching what you already know with that, but my role has changed into that of what I do is I still do all assessments of staff that refer themselves into the traumatic stress service, and I also supervise between 40 and 45 EMDR clinicians in the trust, which is they're mostly psychologists, but also there's quite a few art therapists and maybe nurse therapists and CBT therapists. It might be in IAPT or secondary care or in specialised services around the trust. So from all around the trust, I supervise and all this a wide number of therapists. So I do about 10 or 11 supervision groups per month, really, and the plan is for there to be a wider range of EMDR consultants. So EMDR, it grows in the trust. My interest in this is actually growing EMDR in the trust, because I'm sort of very keen on the delivery of EMDR. I think it's a very effective therapy that I'd like to sort of be able to, I'd like the trust to be able to do more of in the in all areas of the trust, really. And so is EMDR something that people have heard of, or is it sort of new to the people?
I think if people are interested in it or know anything about it, it will be outside of like our course. So
Yeah.
I don't know if anyone has any knowledge of it. Feel free.
I think it's unlikely. I mean, when I'm treating members of what I like about treating members of mental health staff with that is actually people know what it stands for, know very vaguely what it is, and know about it rather than knowing what it is. So, and that includes psychiatrists and psychologists, other people that I treat within the traumatic stress service for staff, really. So I think a lot of people have a concept in varying degrees of what CBT is, and maybe may have had some of that, or know somebody who treats it, or have had the basic concepts laid out to the very least. So EMDR is something that people are less likely to know about. So really there are two treatments for the, and recommended in the NICE guidelines, are two treatments for PTSD, and that's trauma-focused CBT and EMDR. Actually, I think one of my slides later I mention. Yeah, I'll go and talk about those later. So there's trauma-focused CBT and EMDR. So EMDR, both of these aim to process the memories that people have experienced. So you may know more about trauma and about the concept of people's memory being stuck, a particular traumatic memory, then being stuck in that memory. The memory hasn't processed, and so that the individual is left with any reminders or so on from the event or anything that reminds them of what they went through, that is likely to cause distress, maybe panic type of symptoms, physiological reaction, avoidance, and various other kind of things, really. So what we want to do, so it's thought that in EMDR particularly, is it's seen as the REM sleep, when people are asleep and the eyes are moving behind their eyelids and they're sleeping. That's considered to be one of the ways in which we as people we process the events of the day and the stuff that's happened in our life in that day. We process the events with our REM sleep, and when there's a high level of distress in a certain event, which might be the case in with trauma, then the mind then struggles to be able to process that naturally, and it remains stuck, really. So the person is kind of stuck in that memory, and so therefore when they get reminded of it, then they cause the distress. So an example, if I give a fake example, if I was attacked by a gang in the street and beaten up 2 years ago, and perhaps it's too distressing for me to get my head around at the time, and so actually I've been struggling for a while with the symptoms of that, perhaps feeling fearful in public spaces and those sort of things. Now, within the first month, that's to be expected, because it gives that can be how long it's the amount of time it takes our minds to kind of work through that information. So trauma focused therapy is not offered within the first month, it's offered after that. And so, you know, so the when we're looking back at that sort of situation, it's the problem isn't that I felt fear and these other emotions at the time. The problem is that whenever I'm going, you know, in a busy area, I'm feeling that same fear. I'm looking around me, you know, and I'm very on edge and I'm jumpy and these sort of things. So that's the symptoms of trauma that's stuck with me, because I'm stuck in that moment. These are reminders taking me back to that moment when I was in that violent incident. So what we do in any trauma therapy would be to process that, to make that become more part of the past, and for people to be able to discriminate between, you know, what happened in the past and update those memories, really. So with EMDR we do that, and there's a number of benefits, I think, with EMDR over CBT. So subsequently, I haven't done trauma focused CBT for a long time, because I'm doing EMDR. I find there's a quicker and easier way to get a good outcome, then that seems to be the obvious way to deal with that. So with EMDR, there's I would get people to focus on a traumatic memory, or to identify a negative belief they have about themselves at the time, which might be I'm in danger, it might be I'm a bad person, it might be I'm not good enough. So these things obviously can maybe can be brought on from experiences as a child, maybe developmental stuff where people feel they're left feeling that they're not good enough, could maybe never getting approval from parents, or these sort of things. So we're able to focus on these distressing memories and the negative beliefs they have about themselves, and then do what we call BLS, which is bilateral stimulation, which is the EM part of EMDR, is eye movement. So eye movement desensitization and reprocessing is what EMDR stands for, and the eye movement bit is where I'm probably, if I'm seeing someone face to face, I'm sat alongside them and I'm doing eye movements, getting to trap my fingers back and forth like that for about 30 or 40 seconds, and then I'd say, what do you notice now? Because if I've got those to focus on those elements, I'm expecting after a while that there'll be some change in the experience of the memory. It'll feel less distressing, and also it might change different parts as well. And it becomes more adaptive. And so what you find is the logical mind, now what they know about that now, is informing their sort of their trauma memory. So where they might have a memory of a physical abuse at the age of 5, for example, but they might feel they were, you know, in the gut feeling is irresponsible, but logically they know no 5-year-old should be, you know, is responsible for the physical abuse. As you process that sort of that memory, it brings their logical mind online. They realize, actually, well, actually that's not my fault. It was, you know, that's bad parenting and so on. So this can so it sounds like it's, you know, it sounds strange in the way you're describing it, and it's when I'm talking to patients about it, I do say you don't have to necessarily understand it, because I think you tend to understand it more when you've been through that. So it's you know, when you've either delivered or received the training, or both. And it is a very body orientated therapy. So I'm more asking a lot about what you notice in your body. And it's you know, and I will ask for people any change in their body. And people sometimes describe, well, if anyone's been injured in the trauma they're talking about, then they always will feel pain in the part they're injured in. If you're treating somebody who's been stabbed, inevitably they'll feel pain where the stab was, even though it was like 20 years ago, and that's, you know, healed up in a long time ago. So these are trauma memories. So people may have heard of the book "The Body Keeps the Score" by Bessel van der Kolk, and that sort of explains way better than I just have about a lot about these things in quite greater detail. And so I'd recommend that if anyone hasn't read that, it's a good thing to read, just to get your head around trauma and EMDR and different types of therapy and stuff. And so it's the kind of the best book to recommend on for, you know, for more interest in that sort of area, really. So so when I'm treating staff members, everyone gets EMDR, basically, partly because it's my service and I want to do EMDR, but also because it's been found to be the most cost-effective treatment for therapy. And one of the big things for me is actually with trauma-focused CBT. If any of you are having therapy with me with trauma-focused CBT, I'll be saying that this is your homework. You've got to think about the memory when you get home, and you've got to go through either recording it in your mind, either recording it on your phone maybe, and to follow some imagery, which for a lot of people I don't want to do. I don't want to go and think about that sort of those horrible incidents when I'm sat at home with my family. The EMDR, you're processing a session, and yeah, stuff might be going around their mind, might get more thoughts of the memory, but basically sort of we pick it up next time, and we allow that those memories to perhaps tick over. They might have some further processing between the sessions, but they don't have to do anything. They don't have to go and think about the trauma. Certainly the veterans community very much like EMDR, the very practical nature of it, going through it, and if it doesn't feel as touchy-feely. It feels a bit weird sometimes doing it when you explain it to people, but it's not sort of it's not one that sort of like people can necessarily feel is like that more touchy-feely. So I think it's very more pragmatic type of therapy. So so I also supervise a number of therapists in different parts of the trust delivering that. So in secondary care, and in early intervention and psychosis services, in IAP services, and in perinatal services. I also oversee a couple of services that are delivering treatment for women who've experienced trauma or loss during the pregnancy journey, and they're largely doing EMDR and compassion focused therapy with that client group as well. So it's a therapy that I'm on a bit of a mission to try and get that more freely available to people across the trust. Not that everyone needs to have that, nothing else, but actually that it needs to be adapted more, because I think the one thing is generally in most trusts is that there's not much of it available, and so it's a sort of a bit of a mission to make that more available. And it's been going in the right direction. We managed to get some in-house training in AWP last year, so there was previously around 50 therapists using EMDR, and then we trained up another 24, so that was another almost 50% increase in people able to deliver that therapy. So it's something that's growing. It's still referred to as a new therapy or as a novel therapy if you see it in the media or anything, but it's been around since the late 80s, so it's not that new. But it seemed, but it's taken a while to get some footing, because if you look at the reasons things get put into the NICE guidelines is largely because of the research funding around things. So CBT is a massive, big machine, big monster that sucks up all the funding and stuff, and so it's difficult to get in around a behemoth like that, really. So EMDR is coming through with some really good outcomes, and the research done a couple of years ago was done by some eminent CBT therapists and EMDR therapists looking at comparing the two, and it's found that EMDR was clearly the most cost-effective treatment for PTSD. So that's and also I use it in many other things as well, in a variety of other kind of the diagnoses, but it most obviously fits with PTSD, but I use it in OCD or panic disorder and various other kind of things, depression and so on. I've also used it with people with more compulsive behavior, like I've treated a flasher who was struggling with offending, so we use EMDR to treat that, and he was able to then no longer be offending, as far as I'm aware, and that just treating that compulsive behavior. So there's for people who want more information on that, so if you go to EMDR, emdrassociation.org.uk, then that's where you can find out lots of things like videos and other information and press releases about EMDR. And it's a very interesting treatment. One thing I said about training in EMDR is actually that people do need to have another therapy background to be able to train in EMDR. So my CBT therapy was that, because the EMDR training isn't extensive, so it needs to go on top of another therapy that you're already delivering. So you get people who are also trained psychodynamically, or people who are counselors, or other kind of therapy, or clinical psychologists can go straight onto EMDR training. So it's sort of you need to have other therapies. It's not going to teach you all your basic psychotherapeutic techniques, right? So being with somebody, the transference, all those sort of things are not taught on EMDR training. So therefore that needs to be something that something needs to have that training already, to be able to add EMDR to that. Just mention a couple of bits about working with military veterans I did for 7 years. There's a bit of a been a bit of change more recently in the NICE guidelines about EMDR being recommended for military veterans, but that's a bit of a nonsense really, because going back to what I said about research and about CBT being a big machine that's developing, that has the funds to be able to put itself forward for recommendations. But basically, working with military veterans is the same as any other trauma, although they are obviously often quite complex, in so much that actually their experiences in the military arena might be quite complex. And it also added to that the transition of coming out of the forces, which can often create its own problems, where people become quite dependent on a working environment that actually is like a family, really. To get kind of a bereavement, people coming out of the military sometimes. Yeah, people are quite de-skilled coming out. No, they've been trained to do one thing, and that doesn't have maybe any context in civilian life, and people are struggling then to find. And like we get then is you get where a situation where perhaps quite typically then you get maybe the male soldier with a wife that she has to move whenever he gets posted to different places, and then coming out of the forces, then you've got the ex-forces person then can't find a job, perhaps can't find a suitable occupation, and then it lands on the wife to be able to have to support the family. And it's a massive role reversal there, where it's from a traditional sort of role where the man is the breadwinner and the wife follows around around the country or different countries with him. Then it's then he's no longer the provider. He can't actually get a job, and it's reliant on the wife to be able to provide for the family, and it leaves them feeling quite useless and lots of negative self-perceptions around that. That's obviously just a very typical setting. There's obviously lots of cases where there's a woman soldier, and there's lots of different takes on that, of course, but in a very standard and typical way, that's what you get. So transition, you're looking at people being able to make a go of it after leaving the forces. I mean, it's different. When I was in only for 4 years, and it didn't make a difference to me, but you can get people leaving the forces after 40, at the age of 40, after 22 years, and they've never had to cook a meal, they've never had to pay any bills or find a flat to rent, and they're de-skilled in lots of ways in this life that we're all so used to, really, being outside in civilian life. Engagement, finding being able to engage with people can take a long time sometimes, to work with people who are from military background, for them to trust you and to be able to talk through these things. And also some of the complexity also comes from the fact that a lot of recruitment for the army in particular comes from working class areas, estates and so on, from lots from the northeast and stuff, from Manchester, Liverpool, and that sort of thing. And of course, there's a more likelihood that they're going to have some childhood trauma within that. So quite often you come across somebody, and really, although our remit in the veteran service was mainly to deal with military trauma, but people coming with loads of developmental trauma as well, which makes it a much more complex and challenging picture. But it's quite enjoyable work, quite challenging. And I said I was there for 7 years, and that was enough for me. It's quite a political area, really, because there's lots of non-statutory services, Health Heroes and Combat Stress and British Legion, and many other lesser known ones. It's quite quite a difficult, a different area in that respect. So that's I say with that. So my role doesn't typically involve research, but having been involved in research from time to time. So there's a few of the ones that I've been involved in. When I was in Cardiff, I was involved in the systematic review and meta-analysis of psychosocial interventions for veterans of the military, and that doesn't really tell us what anything new that we already know about. So the recommended treatments are trauma-focused cognitive behavioral therapy and EMDR, really. So the treatments for PTSD are the recommended ones there. I guess my colleague was the one that the lead researcher on that, and did lots of the hard work on it. And I think it's important to get these papers out, which are actually pointing out what's best for a particular user group. Then in AWP, then I've been involved in the drug use in street sex workers study protocol, a feasibility and acceptability study of complex interventions to reduce illicit drug use of dependent female street sex workers. So quite a catchy title. And that's another very, very challenging group, because actually the whole premise was that you're working with people with illicit drug use, which really with most trauma focused therapies, that you're not, they're people that you'd rule out because of their drug use. So already you're up against it because you're working with a group who by their very nature should be excluded from your caseload anyway. And there was some moderate improvements with that. It wasn't necessarily anything that sort of that came up with anything amazing with that, because lots of problems that were along the way with that service. I think what surprised me the most actually was that most of them the women who were going forward getting treatment didn't cite any experiences as street sex workers as their main traumas. They're all other kind of traumas that happened maybe leading to that, but it was some interesting sort of bits of like that came out of it. I was involved with the ARMS study. So it's providing EMDR for the at-risk mental state people. So really sort of EMDR for psychosis, which is really fascinating, and potential for that to grow really. So working with some really unwell people and seeing how EMDR can work with a much more complex group, because it's recommended already for PTSD, single event trauma, someone in a car crash or an assault and that sort of thing. But actually, as with complex, secondary care, mental health sort of stuff, that's relatively new stuff. There's not so much of that going around. So that's an interesting study that went on there with that. And evaluating outcomes and experience of AWP's traumatic stress service support service. So this is obviously an evaluation of my own service. So although I'm not sort of a lead researcher on this, I'm put in as a bit of a co-author, I think, because it's basically evaluating service that I've been running myself for the last 7 years, and then I've been doing a lot of treatment in it myself, and the outcomes on it have been really good. So the average reduction, I don't know if anyone's aware of the impact event scale. It's the most common rate. Well, it's a common rating scale, but we have been using. It's been phased out now in favor of other rating scales. But the impact event scale is a 0 to 88 scale on rating PTSD symptoms, and 33 and above is probable PTSD. So in that, there's been an average drop of around 38 points on the impact event scale. So massive improvement for people that complete treatment within the service. So it's been really good to have the outcomes from my service, and we're in the process of trying to get it published now. Looking at a couple of journals, at least there's been a psychology assistant who's been on the case with that, and it's putting that through as a service improvement project, but also evaluating and seeing where we are and what we've been able to achieve with that. So I've been able to present that to the executive board of the trust, and it should be published as a paper sort of fairly soon. So that's sort of it's very much a source of pride of me, because actually it's not so much the paper, but actually that it's actually the service that I've been part of for the last 7 years that really is being discussed there. And also, interestingly, a significant change in the scores for depression and anxiety as well, as measured on the PHQ, the depression scale, and the GAD-7, that's the anxiety scale. So significant shift in those as well. So I did have another there's a whole different sort of presentation on that, but I'm not going to go through that because I've been talking for quite a while now anyway. I think that's the end of the presentation. Should I go to questions now?